This week, in our tabletop conversations, we sat down and talked with Doctors Glen Tinkoff from University Hospitals in Cleveland, Ohio, and Dr. Linda Dultz from the University of Texas Southwestern in Dallas, Texas, to dive a little bit deeper into their views on the role of the physician in injury and violence prevention work. We'll talk a little bit about the history of how prevention was integrated into our healthcare systems, how physicians should be involved with the work, and finally, the relationship between physicians and the injury and violence prevention professional. So good to see you. Appreciate you being in our conversation today. Um, Prior to us starting recording, we were talking a little bit about kind of some of the historical context of where injury prevention has been in our world. Glenn, can you actually give us a little insight to what has been our history as far as the physicians and how injury prevention has been viewed in our world?
Yeah, I can. Fortunately, and I've been around long enough to see this evolved from the development of a concept of a continuum of care for trauma patient, for the care of a trauma patient, from the time of injury to the time of recovery and reentry into society. One of the concepts that were difficult to grasp was injury prevention at that time. I was fortunate enough to be on the Committee on Trauma and was on the executive committee for some time, and was able to watch this develop and participate in it. I was able to. I was honored to chair two of our professional organizations committees, East and AAST. With that background, what I realized is how ignorant I was of injury prevention and public health. But fortunately, we have really a finite group, but a very knowledgeable and productive group of individuals like Linda who have educated themselves in public health and have published and our professional journals are now actually publishing their papers, which was wonderful. That's what I pushed for the last 10 years, is to have a voice in our discipline. So I'd like to pass this over to Linda to introduce herself and her background and why the heck she would concentrate on an MPH on top of everything else she's done, including just have her third child.
Yeah. So I mean, first of all, I just want to say thank you to you and the rest of the members of AAST and East that kind of led the way for physicians to get involved in injury prevention. I think, we talk about injury prevention professionals, really being the core members of, leading the way in terms of advocacy and, creating these programs for car seats or burn safety, et cetera. And, really the question I think is, how does a physician get involved? During my training, and it sounds like similar to yours, injury prevention just wasn't a thing. I was never exposed to it either. And I had an MPH, and I was more interested in just healthcare economics or international health. And I really didn't think of injury prevention per se as a field until I got into fellowship. And then I really got exposed more so into injury prevention and gun violence and advocacy, really. And that's what sparked my interest to figure out what role the physician can play in injury prevention. And so I'm still early in my career, but I'm grateful to East and the AAST because now I'm also a member of the injury prevention committees on both organizations. And that, I think, has really been a gateway for me to get involved as far as like a national level, to understand the the issues and how physicians can get involved. So those two organizations have really helped me expand my knowledge, network, figure out what I can do to be a part of this group. The other thing I think is really working alongside your injury prevention professional at your organization, which a lot of organizations don't have one. I'm fortunate and enough to be working at a level 1 academic trauma center, and I have a phenomenal injury prevention professional that I work with. And so her and I now, try and have meetings and collaborate and play off of each other to come up with ideas of how we can come together, I think, to figure out ways to improve our community and, to get our programs out in our community.
So on that note, Dr. Dultz, would you say, actually this could be for Glenn or Linda, would you say that this is typically the physician that's coming to the prevention professional, or should it be going the other way where the prevention professionals are reaching out to the physician as far as how these projects and this work can be advanced?
You want to take that, Linda, or I can?
I'd love to hear both.
Structurally, that's a structural and process issue, really, and it may vary. I want to go back to what Linda said. What she mentioned was one of the attractions is advocacy. I also backed into injury prevention because of advocacy. It is a way for us to make change in our communities, at our state and national level, and you can see it happening now. It's very relevant. But with that said, that's one of the real difficulties of how much advocacy takes so much work and so much effort. I see our injury prevention professionals as the face of our effort all over the region that we serve. And they're the external face of trauma care, similar to what our air medical programs often are, but flying with the branding of our trauma centers. Our injury prevention professionals have to give the right message, the apolitical message of injury prevention all through our communities, especially in the governmental and legislative areas and that we have access to. With that said, I don't think you can dictate the structure of any individual program, but you have to look for the ones that are those persons within the program that are going to organize themselves. So what am I talking about? It's often hard to find trauma. We've always found this hard. It's hard to find the group of trauma surgeons that will give the time, effort to do this, because it's hard, especially the advocacy role, because it can take so much time and effort, and it's frustrating. State legislatures are every 2-year events to get anything through. So that's on one end. The IPP relationship often is the key, is that they need to be facilitators, and there needs to be a way to communicate. So that dyad is very important, and it may not be the trauma medical director that's the point person for that. I've often assigned somebody else to do that, because it is an external job to be present in these efforts to do that, and you have to want to do it. It can be, as I said, awfully frustrating. I don't know what your experience is, Linda, but those are my experiences with injury prevention professionals. But they must have a point person within the program. They must have somebody, meaning the physician. There must be a go-to person.
Yeah, I agree. I think having that injury prevention professional, or whoever that point person is in your organization is really key. That has to be, the glue that binds everything together, really. And I would say that the physician really shouldn't be the leader, but like more of a component, and how to use the physician wisely within injury prevention. Advocacy, I think, is phenomenal. Using one of the COT programs, Stop the Bleed, we help teach those programs. We help get those messages out there. Using our perspective of just seeing the injuries or seeing the patients and how we can implement certain programs within the hospital per se. I think all of those are important as the physician, but running a project from start to finish is really challenging, especially because the standard, or I wouldn't say the standard, but when you think of a physician in academics, you think of somebody that's doing research that has funding. There really is very little funding in injury prevention. I mean, almost nothing. And so to be able to have an institution fully support, the trauma surgeon going out into the community, and utilizing the institution's resources to do that, it's challenging. And so you're kind of stuck because you have all this clinical work, and no funding, and so it's hard to really push those messages forward. And so I would say that the physician should really be part of the team, and really rely on the injury prevention professional to see things through.
So would there be anything that either one of you could say to your fellow physicians as far as what could they be doing as their first step if they're not involved, or they feel like or even to the professionals themselves where they feel like they don't necessarily have the support of a physician or go to? Is there something that we could do as like a first step for our professionals, whether they either be the physician professional or the injury professional?
Well, just briefly, the program, program personnel, and specifically in the bigger programs where there are multiple personnel, need a voice within the larger program. Stuart talks about big P's and little P's, and I get confused quite often when he does that. But the fact is the big P of the trauma program and all its facets, it needs to be introduced to all the programs. So in your operations meeting, they need some time to talk about all the things they do and the outcomes. And where there is funding, but you have to search for it. And those things that are especially funded locally, and we've done that successfully when I was in Delaware for many years, is to work with state and because the state can get access to federal funding to initiate a violence intervention program. That's how we started ours, because it was relevant. So all those things need to be addressed and be talked about in that operations committee. And we gave an audience for our injury prevention professional to talk about those things with the rest of the trauma operations group. So that's one way. And two, it's a structural aspect. Have meetings, and invite anybody, like our research meeting. Anybody who's interested, come and let's talk about it. What are you interested in doing? And participate. If you're asked by that person to participate.
Linda, any final thoughts?
No, I mean, I agree with all of it. I think just for me, at least, networking is the biggest way that I kind of just fell into it, and just started meeting people and started talking to people. And I'm still very, new in the field, and that's how, I'm just kind of getting my feet wet in it. So I would advise anybody else to just do the same.
Yeah, if my injury prevention professionals tells me to show up, I better show up. Yeah. And what they have to do for me is, what am I talking about? And am I knowledgeable enough to speak knowledgeably about it? So educate me, because I'm at many times I'm the prop, and I understand my role. I have the white coat, and I'm important, but they have the better grasp of the issue, and they need to keep me abreast of what that issue is, and what our voice is, and it must be apolitical. It must be. It must be for the patient.
Well, yeah, I definitely agree. And I just want to thank you both so much for participating with us today in this conversation. I think there's a lot of valuable points that both the injury prevention professional would really benefit from, as well as hopefully some of our physician colleagues would also benefit from your points today. Just want to say thanks so much and really appreciate it.
Thank you.
You're welcome. And thank you for the invite. I really appreciate it.
Thanks for watching, and remember to subscribe.